I wanted to go back to where everything started, going back to rural Punjab. That was my hometown, and I always thought this is where I want to be. Again, it's in retrospect, it's easy to say that all I wanted to do was anterior approach, but I went back as an arthroplasty surgeon. But I tried to find out my niche, that I want to develop a shoulder practice. And there were many hiccups in starting a new practice, which when I finished my fellowship, my bosses told me that you will learn more in the first year of practice than whatever you think you've learned in whatever training. And they were true. This was totally new in India. Apart from people I could count on my hand who were doing it in big metro cities with in a medical college setup with huge years of experience, or this was in rural Punjab. And I guess anywhere in rural would have the same issues. Number one was how much are people open for a young guy to come do this new approach? Second is in the world we live in, people need to filter through that. Is this a marketing gimmick, or is there real cultural or significant clinical value in it? So from day one, I was trying to make a point that this is not a marketing gimmick. I was very honest in going to every forum I went that this needs proper training. It is not something that you can see on View Medi and do it. But like anything else, the day, it's just like driving a car. You need to learn it. You need to learn it in a proper manner. You better learn it early versus late so that your muscles and your reflexes are more known to it. And I made it very clear that I'm not here to say or promote an approach that this anterior approach is better than any other approach, but these are the selected benefits that there's going to be early recovery in the first 6 weeks. There are going to be less chances of dislocation. You can send your patients much earlier. And if you're well trained in it, this is something you don't need to cherry pick your patients. You can do it in all your patients. It's obviously end of the day up to you what you're comfortable in doing. Number one limiting factor was the socioeconomic aspect. The hospital or anywhere else, the budgets to do it on a, let's say, expensive table, which like anything else is expensive, to make it adaptable to this environment, it had to be frugal. That's just how things work in India. You can't come and be picky and choosy of wanting the best fancy equipment to do it. So luckily, I was trained off table and on the HANA table. So my inhibition on not doing it off table wasn't there. So I said, okay, I should stop cribbing about the HANA table. Let's just start with what we have. So number one was doing it on a standard table. Second was, again, during my Canadian journey, I learned it to do with regular instruments as well, not with specialized instruments, but offset femoral broach handles. This is one limiting factor that were absolutely must. I at least in my hands, I thought this was this specialized equipment that I need to do it safely because that's how I had trained. Getting those was a limiting factor. Again, I need to give credit to one of the young surgeons in Bombay, Dr. Supreet. He was another guy who was in my kind of a boat. He had come back from Australia, but luckily he had managed to arrange the special equipment as well. And he was very kind in lending me this femoral broach handles and out of other things. So and he really pushed me. He said, look, no one else is doing it in the North. I'll help you set it up. Why don't you start doing it? So again, yes, so it started with someone being kind enough to give me their femoral broach handles. So this was a starting limiting factor. Second is training your staff to do it. By staff, I mean the peripheral staff, the surgical assists, talking about anesthesia. And number one question sometimes people ask is, it's well established that traditional hip replacement is a great surgery. It's like a Toyota truck. Why are you trying to fix something that ain't broken? So one was trying to convince them that there are benefits to it. That was one limiting factor in rural Punjab. They're like, look, man, you're not in California. You're not in Vegas. Why don't you stick to what's traditionally doing well? And I don't disagree with them. Hips, lateral and posterior approach were doing well, but I was passionate about it. Trying to get them equally passionate about it needed effort, right? And now I think about it, just because I had trained on it, I had seen why was I expecting people who weren't exposed to it, or someone in anesthesia, or someone as a surgical assist, why would they be passionate about it? Why would my patient, if I haven't talked to them about it? I was thinking back of my patient would be like, hey, you've learned anterior approach. Let's just do it. But that doesn't work that way, right? So another limiting factor was trying to get the periphery as passionate enough for what I was passionate in. So, like I said, going to forums, talking to my fellow colleagues, talking to patients about the benefits of it, and also training my surgical staff in doing it. Training your staff, because surgery is not one person game, it's a team game. Second was there was no one else nearby doing it. And end of the day, I'm human. People can end up having complications. All my bosses have told stories of their complications. My biggest hindrance was I was in up north. Who's going to come bail me out if, God forbid, something's going to happen? So, it's just about planning. So at that time, every time we did it, my staff had a plan B. I said, I hope we don't have to do this, but if I get stuck, we'll be tilting the patient in, doing the traditional approach. And so these are all plan B and C's, which we always had in place. Touch wood, up till now, I didn't have to execute it. The third thing since I was beginning in practice, I was taking a lot of time in doing my cases. It was also a personal mental struggle. I said, when I was a fellow with my boss standing behind me, I was doing it in 1/4 the time. It's still the same. Why is it taking time? Why is it taking time? But in retrospect, these are things that come with it. So initially, when I would be taking 3 times the time for a basic primary, it's just the look on the nurses' faces, the look on the anesthesia faces. And then you start questioning yourself also that, am I doing the right thing? But the proof of the pudding was that when they saw those patients on the same night or the next day, things like we were giving them so many less painkillers, our opioid use decreased, we were mobilizing them the same night, even though the same anesthesia staff and the surgical staff who were maybe mentally in their mind cursing me when I was taking 3 times the more time, when they saw those patients the next day or the same night and the relief they had, it was the staff that on God board that, you know what, you're doing the right thing. So all of these things really encouraged in getting things flowing. Then the other thing was when I started presenting these cases, what happens is that when you're a young surgeon and you're not the high volume big bosses, you get the more technically challenging ones. And in India, our patient profile is a bit different from what the North American profile is. Again, like I said, because of socioeconomic disparity, we still get cases which are now unheard of in the Western world. Let's say a neglected neck of femur fracture. In the Western world, there are pathways that these things should not be neglected. But neglected neck of femurs make a bulk of our practice. Neglected rheumatoid deformities, unfortunately, make a bulk of our practice. Sometimes people don't take the DMRDs or the anti-rheumatoid treatment they should be taking, and these leads to deformities which now in the Western world are very less seen. I couldn't cherry pick my cases. If I wanted to do the anterior approach, I had to take all those cases which the books say don't do them initially. I knew that I've been trained by good people. I was lucky enough to get a much more anterior exposure during my fellowships than maybe someone else would have had. So with that belief in mind and a prayer every morning, we took up cases, they call them the elephant ear pelvises, the Mickey Mouse pelvises, the high BMIs. Take it with a grain of salt that we don't get to see the 40 BMIs and 50 BMIs in India, but we do get to see the BMI 35 and 40. They're still short and stout. What I'm trying to say is the complex cases. We early in practice in India, surgeons don't get what we say as a good pathology. We get the neglected ones.